to the Small County Fiscal webinar. We'll get started in just a minute. Just a few things that we always have to say. You're all on mute. If you want to ask questions, and pausing throughout the presentation to ask for questions, go ahead and type them in the question box, or click the hand icon by your name, and then we can unmute you and you can verbally ask the question. Just want to let you know that the next Fiscal Leadership Institute will be on June 4th and 5th at the DoubleTree Hotel in Sacramento, and registration materials should be today or tomorrow. The next webinar is going to be on April 26th, and we'll talk a little bit about that at the end. So, to Mike.
Great, thank you, Shoshana. Good morning. So today what we're going to go through are a lot of the issues that were discussed at the CBHDA Financial Services Committee IT meeting on March 8th. You can see the list of items there that were discussed and we'll talk about today. Starting off with the Office of Inspector General Audit. I'm guessing most of you are, if not all of you, are aware of the OIG Audit of Federal Fiscal Year 2014 Medi-Cal, especially mental health program, where the OIG identified claims that were approved inappropriately. I've not seen the report personally, so I'm not sure what the specifics were as to why there were disallowances. It was not, and my understanding, it was a sample of 500 claims or charts that they reviewed from various counties throughout the system. And they took their results and then extrapolated those to the entire system. And the bottom line was about $230 million of disallowances or recoupment that the OIG found based on their review. DHCS shared the report as well as the methodology that the OIG used with both the Directors Association and CSAC. And CBHDA doesn't agree that that you folks, that you counties, should be 100% responsible for the entire recoupment, since some of this rests with the Department of Health Care Services. And so CBHDA has been working with CSAC and the County Councils Association on potential next steps with respect to how to figure out who should be responsible for what. DHCS apparently submitted a response to the OIG. It was due on March 2nd. And then the final OIG report should be issued over the next several months. And at the time of the meeting, no one was sure when that would occur. And then DHCS indicated that they're looking at how to allocate the recoupment among the counties, since it's it's tied to some specific claims in the sample, but the overall dollar amount obviously is not tied to specific claims because it's an extrapolation. And so how should that be allocated among all of you folks? And again, CBHDA doesn't agree with that you folks should be responsible for all of this. So the one thing that DHCS did state is that this doesn't sound like it will be resolved this fiscal year, and they are saying that they're potentially going to offset your 18-19 behavioral health subaccount distributions for the amount that is determined to be relevant to each individual county. And there's some issues around that I don't know if DHCS has thought it all the way through or has asked the counties for their input, and hopefully they will. But specifically the behavioral health subaccount may or may not have been used to fund these services. So you may have used 1991 realignment or MHSA So for them to recoup from there may not be totally appropriate, as well as the behavioral health subaccount, as you know, is also used for substance use disorders. So to the extent they start offsetting your behavioral health subaccount, it may impact the amount of funding, as well as just how a lot of you do accounting. You know, when you receive the distribution, a set percentage goes into substance use disorder. And if they've reduced that dollar amount, uh, you know, basically it ends up having an impact on the SUD side. So again, hopefully you folks will have an opportunity to really consider how you want to have the funds recouped, and be able to provide input to DHCS before they just go ahead and start taking money or offsetting your behavioral health sub-account. So obviously more to come. Any questions, or if anybody has any additional information over and above what was shared at Financial Services Committee?
Not yet.
Okay. But clearly not a happy thing. We then got into a little bit on the drug Medi-Cal update, where DHCS provided us an update on the waiver status. I guess there's 11 counties that are currently operating under the ODS waiver. There's another 11 that are approved to go ahead and go live. And then there are 10 that the DHCS is reviewing their fiscal plans. So quite a few counties now coming in under the ODS waiver. There's been 84 million in total approved claims, and that's both FFP and the state and local match since February 2017 in the ODS waiver. So just kind of an update on the status there. And then we talked a little bit about DHCS is increasing the drug Medi-Cal claim submission time frame from 30 days to 6 months. However, they have not implemented the system change. So even though they've said this is the new policy, their current business rules still apply to the actual system. And so you would, if you submitted a claim that was over the 30 days, it would get denied at this point, unless you included a delay reason code, you know, again, similar to the old business rules. And there was an email sent out that because of the DHS person on the phone couldn't answer the questions, and it indicated that you could actually hang on to these claims if you have claims that are over 30 days. You could hold on to them waiting for implementation of this system change, and as long as they then fell within the 6 months, you'd get the services approved. But you know, the DHS did not say in the meeting or in the email when they anticipate the system change to be fully implemented. So to the extent that you're holding out claims waiting for the system implementation, you're somewhat subject to the risk that DHCS won't have it implemented timely. And so you're probably better off just going ahead and getting the delay reason code and submitting the claims and getting them approved, if rather than waiting for DHCS to do this at this point. So any other questions, or any questions on that, or if folks have additional information since the Financial Services Committee meeting? All right. One other thing that was brought up during the meeting by Chuck Anders from DHCS is that DHCS is analyzing moving from HCPT codes claiming to CPT codes. And he stated the reasons are CMS reporting requirements under the mega rule under Medicaid, that they need additional detail level for some of their audit reports, and that they need that level of information for the performance outcome systems. At this point, he said they're only looking at mental health. and not substance use disorder services, but that they probably would have to look at drug Medi-Cal in the future. They also, DHCS surveyed you folks and kind of had a mixed results in terms of who's using CPT codes. Some do, some don't, as well as there are some that do use CPT codes, but they're not in their electronic health record. This is a longer term project, Chuck indicated, so it's not something they're looking at trying to do. I would imagine it would be at least a couple years away. And because there's also no real easy interim crosswalk between the two, I guess. And so the nice thing is that there are potential impacts on the cost report, where bottom line is we could eliminate modes and service function codes if the state wanted to. They could just do the CPT code claiming, and you could start to do cost reporting, based on either staff costs or client contacts based on the CPT codes, rather than having to do modes of service and service function codes. So it has the potential to simplify cost reporting. And really you end up just with reimbursable cost centers and non-reimbursable cost centers. So for all what we now call the Mode 45 and Mode 60 activities, those are just reported as non-reimbursable cost centers. So hopefully as part of this, he said the reasons were all these reporting requirements, but really it gives you folks an opportunity to look at the overall reimbursement approach. And I'm talking about simplifying cost reports, but hopefully it'll go further than that, and you'll have an opportunity to consider whether you want to get out of cost reimbursement altogether and look at more of some sort of prospective payment system based on case rates or capitation, or even a global budgeting sort of approach that we've talked about previously. We've been talking about for 4 or 5 years, getting out of this minute to service, retrospective cost reimbursement, and hopefully the state at least considers that or gives you folks the opportunity to provide input into that, so that there could be some benefits to this. So anyway, that's all that I had on that. Any questions or any other input into that topic?
There's a question going back to the drug Medi-Cal ODS waiver. Question is, will FFP reimbursement percentages in the waiver be similar to historic FFP reimbursement percentages?
Yeah, so the FMAP, or the percentage of reimbursement of FFP, is really driven by the client's aid code, so that shouldn't change. You also get some state general funds for some of the new services under the waiver, but yeah, the FFP should be the same. But the downside is, again, it's some of this new stuff, and as well as, and we'll probably talk about it when I talk about these information notices, all these that are really big impact on you folks are all these additional requirements, not just under the ODS, but under drug Medi-Cal in general. But anyway, it is the same percentage. So let's go ahead and move on to the information notices. And all these except the top one were discussed in the Financial Services Committee. And so I'm going to cut over to the actual info notices. And hopefully you're all aware of how to get at these information notices. If you are at the Department of Healthcare Services website, you go under Forms, Laws, and Publications, Letters, Information Notices, and Bulletins, Mental Health Services, and then the current ones are up top. You've got prior ones from 2014 to 2017, and then all the older ones are here. A lot of those deal with the MHSA program. So anyway, moving into some of these information notices. So I put 18-015 on here because I've received some questions on it, and I just want to kind of make sure everybody understands that first of all, this isn't anything new. It's something DHCS put in place basically when the SMAs went away, and they no longer had any sort of controls in the claims processing system for billing rates. And so really this is to limit the rates or the interim Medi-Cal payments to contract providers that you contract with when the rate that you're putting into the system is different, or the rate that they're putting into the system is different than the rate that you pay them. And so really it probably doesn't apply to many, if any of you, but it was put in place for counties who allow their contractors to enter their own information, including rates. And so anyway, again, for most of you, it doesn't apply. You don't need to do it. And I think the main thing you want to focus on is you continue to submit your Medi-Cal claims based on the actual rates that you pay your contract providers. And if you're doing that and your system reflects that, and you have control over that, then you don't have to really pay attention to this information notice. Any questions on that one? All right, then the next one that we did discuss in the meeting was 18012, which had to do with how to claim for both federal dollars and the state general fund for costs related to the Medicaid final rule implementation. And the state made it very clear that these are only for new costs that are incurred by the county. So, and we talked about this a little bit, or it was discussed there on what's, hiring new employees. Well, it's not necessarily that you have to have a new employee, but you have to have a new position. So if you take an existing position and just give them more duties, that's not a new cost. You'd need to actually create a position or a half a position, or you have the ability to contract this stuff out. The other thing they mention in here is that they modified their claim forms, but I've got to be honest with you. So I saw it when I looked at the 1982B. It's clearly here's where you put in your costs associated with the Medicaid managed care final rule. But I didn't see it on the 1982C. I don't see anywhere on here where you're allowed to do that. So I don't see where they actually modified the 1982C for your monthly claim for URQA costs. The other thing is, just as a heads up, it looks like all this is additive. So where they say actual administrative expenditures, that's after you've already entered the actual costs of doing the POS and the managed care rule stuff up here. And then it calculates everything through, although there's some errors even in the calculation, because if this ends up exceeding the limit, it doesn't limit. But anyway, so it looks like they did amend the 1982B, but not the 1982C. The other thing that you need to be aware of is that you're going to have to track this separately because this is the claim. But remember, when we do the 1718 cost report, it's going to be, you're going to have to report it somewhat differently on the cost report. And I would imagine that they're going to do something similar to what they did with the 1617 cost report, where you see now they've added, this isn't an admin, but for the services, they're now adding this continuum of care reform. And if you actually look at the 1960, you can see they've added a line underneath administration where you're going to have to identify those costs separately because the way the form works is that it picks that up separately and actually puts the state general fund, or computes the state general fund out on the 1992 here, where it's coming from by looking at that what you put into that field. So I would imagine you're going to have to track all this stuff now separately. Make sure you're doing that to the extent that it's not just claiming, but it ultimately will be settled through the cost report. And so that was it on this one. And, you know, again, look at the info notice. You can see all these different activities. Anybody have any questions on that? I think it's fairly straightforward. Just kind of a nightmare to track, and hopefully the audit, you know, hopefully they go smoothly and the auditors don't interpret something significantly different than what the intent was. All right, then moving on to the network adequacy standards. I think the biggest thing that I just wanted to point out there was that you've got to submit this network adequacy certification tool by March 31st. So that's like next Friday. So just kind of make sure you're aware of that. And again, you can look at the info notice is pretty large and all the enclosures you've got to do. Same with this federal grievance and appeal system requirements that was discussed. And you can see again a bunch of things you need to pay attention to and take a look at that. And then we didn't really talk about it too much, but it was brought up, this info notice on the diversion of behavioral health sub-account that the state put out this information notice on. There's a couple of things. I mean, the bottom line is kind of this bullet, which is that you're required to pay for all drug Medi-Cal covered services to Medi-Cal beneficiaries of that county, and that's pretty clear in statute, and that's the intent of the behavioral health sub-account is to cover the cost of those services. The one thing though, there's some, you know, when I read this and I looked at some of the statutes, first of all, there's some citations that are inaccurate, but this whole paragraph where it sounds like you're required to contract, and if you don't contract, then they're going to do all this other stuff. It's somewhat misleading because they don't have the authority to do all this stuff if you don't contract. And in fact, the statutes say if a county decides not to enter into a contract, then you've got to notify them, and you've got all this process stuff here that somewhat is not consistent with what this information notice says. So I'm not sure why they were trying to be so heavy-handed with this information notice, but just know again that kind of the bottom line is that you're responsible for the drug Medi-Cal services provided to beneficiaries of your county, and they will either, you know, they may do, I think they're going to do invoices to counties, you know, for the match to that. The other part actually of that information notice that will apply to some of you folks, especially you folks, you counties that are not doing, you know, drug Medi-Cal, is this whole SAFTI block grant funding and allocation. I think the state's really concerned that counties are using the SAFTI funds to basically do drug Medi-Cal services as a way to avoid having to go through all the requirements. And I think they're going to probably start looking at that with much more scrutiny. So just be aware of that. And part of where that's coming from is I've been in some other conversations with some other issues, and the state seems to kind of focus on this. So be aware that if you are a county who isn't doing drug Medi-Cal, but you're using SAFTI monies to do the equivalent, that you may be pushed to go the drug Medi-Cal route. And then the last info notice we talked about was this county of responsibility to pay for adult psychiatric inpatient services and an IMD. Kind of the bottom line again on this is that apparently some counties were using the IMD exclusion as a reason to deny services provided to beneficiaries of their county. And what the IMD exclusion is for certain, if a facility is greater than 16 beds, they are excluded from participation in the Medi-Cal program. And so if you have a Medi-Cal client in an IMD, kind of the bottom line is you're responsible to pay for those services unless you can demonstrate that you've exhausted all resources, and then you have to show that to DHCS, and who knows what that would entail. But bottom line is you can't deny these services, and you're required to pay for them. So that was it on the information notices. It covered kind of a wide variety of different topics there. Any questions or comments? Any additional information? All right. Then moved into the state and federal budget update, which is really I guess it is federal budget update. So the state's looking at the 2011 behavioral health subaccount allocations. Looking at, I guess apparently they have some ideas on the rolling base, which it seems to me like it would be fairly straightforward. So I don't know why it really hasn't been implemented yet. Rolling base just means that your prior year base plus the prior year growth is your new base. The one issue around the behavioral health subaccount is that because the growth historically has somewhat been allocated based on actual claims, you've got an issue with claims lag and the 2-year lag in having final approved claimed amounts. But in any case, I guess DHCS has some ideas around that. And the other thing with this, it may seem fairly straightforward to a lot of us fiscal folks how things should be done. But with any of this, there are politics around it, and maybe some of that's coming into play that are causing this to not occur yet. So in any case, DHCS said they will present both to CBHDA and CSAC some of their recommendations. But given that, I'm still not sure when the 16-17 growth will be released. State's sitting on almost 98.4 million. And I had heard from one county that might be coming up here in May, so you may get those funds this fiscal year, but I'm not sure. And again, going back to the rolling base, I would think for 18-19, it should be the 17-18 base plus your 17-18 growth. And the 17-18 base is a known amount. I mean, that's what you're currently receiving. And the problem is the 17-18 growth, even though the amount will be known, October-ish, you may not have claims that reflect 17-18 claims. And I don't know why you just don't accept that, or I should say you, but I don't know why the state doesn't look at, it's just going to lag by 2 years. So you're going to use, for 17-18 growth, you're going to use 15-16 claims. And so you're just on a 2-year cycle in terms of playing catch up with the claims and the actual growth. And the other part is the methodology that was used for 15-16, I don't believe there was an information notice that went out as to how it was done. I know CBHDA and CSAC have put out letters saying it was done consistent with their recommended approach, which was a combination of claims and risk-adjusted beneficiaries. So assuming that's still the case, it seems to me, and if that's what the approach is going to be going forward, it would seem that you could probably do this fairly straightforward, and so that you can start seeing some of your growth in a more timely manner, as well as know concretely what your base is going to be. And then the other thing, we received a little bit of an update on the SAPD funding. I guess 31 counties have been processed for first quarter payment. There's another 14 in the queue. 14 million have been allocated, and they anticipate the full allocation by the end of the fiscal year. And apparently they're still expending the federal fiscal year 2017 grant award. So any questions or any additional information on either of those two issues? All right. Mental health cost report. So Chuck Anders talked a little bit about the mental health cost report, indicating, and I think this has been discussed several times, where they anticipate settling all outstanding cost reports by the end of 2020. I wasn't sure if that was fiscal year or calendar year, but when he laid out the specific years for each cost report, it sounds like it's going to be fiscal year. So you can see the dates there, 10/11 by June 30th, 2018. Then they're going to settle 2 years worth of cost reports. And the reality is for 10/11, a lot of you folks have already been settled. So I wouldn't think it would be that difficult for them to settle that. 11/12 and 12/13 by the end of this calendar year. And then the next 2 years, 2 fiscal years will be done by the end of fiscal year 18-19. And then another 2 years by the end of calendar year 2019. But the one thing, again, to make sure, this is the initial settlement and not the audit. So it's really just a matter of trying to get caught up on the initial settlement amounts. And remember that the audit has to occur within 3 years after the most recent cost report submission. So if they're saying, and every time, and this is kind of why they force you to do more of an interim settlement reconciliation process and to download and then re-upload, because that really sets the basis for the 3-year audit requirement, even if you had no changes. So if you look at this schedule then, and you apply that to the audits, it basically means they've got to have all these audits done by December 31st, 2022, which, it sounds like they're, we talked about speeding up the audits, but when you look at it, they're already auditing 10/11. And in fact, some counties are done with 10/11. So they're kind of ahead of the game in terms of the audits relative to the settlement process. So the bottom line is it looks like they have about 4.5 years in which they would audit the 6 years of cost reports. So it's really not speeding up that much. The other thing that Chuck said is that they intend to submit cost reports to the auditors, even if there are errors that pop up on their automated error check. And personally, I'm kind of glad with that, because a lot of the errors have to do with a provider not having open a mode 60 service, which makes no sense. You shouldn't have to open in ITWS a mode 60 non-Medi-Cal service and then have your cost report show up as an audit. The other thing that happens constantly, they've never amended the edits to disregard that there's no longer a state general fund managed care allocation. So there's always errors related to the 1994. Also, there's errors that show up constantly because you no longer have the SEP program, the AB 3632, and so you get errors there. So a lot of the errors are what they call false errors. So the fact that they're going to give it to the auditors, I think, is great. And then you can just deal with it at audit. And like I said, it says the auditors are going to increase the speed at which they conduct the audits. It really isn't that much quicker than what they're doing now. Like I said, they've got 4.5 years to do 6 years of cost reports, but they're already kind of doing some of these. So I don't think it's going to be that. They are going to have to speed it up a little bit, but it's not like they're going to have to audit, 2 years. They're not going to have to go 3 years in a row of auditing 2 years worth of cost reports to catch up. because they have a little bit longer to get this stuff done. He also said that when we had the meeting, the 1617 summary template was about to be posted, and it was posted. And then I saw an email from one of the DHCS analysts saying that there are errors on the MH 1992 detail, the EPSDT, and the inpatient-outpatient worksheets where things aren't calculating correctly. And so that analyst said don't use the summary cost report. Anyway, and then DHCS wants you, they did say, somebody asked when's it due, since, technically it's due December 31st. DHCS set a process through Information Notice 17025 that you can go through and submit a formal request, and it sounded like they wanted you to do that, even though really it's their fault that that you couldn't meet the deadline, because the template, and actually even to this date, still, when I looked earlier this morning, it was still the old summary. So technically you can't even submit at this point. But if you want, you can go ahead and do that, request the extension. And then they said they're working on the 1718 template. Again, hopefully cleaning up the summary template based on some of the things I just mentioned, that the 1994 is no longer necessary. None of those state general fund pages are necessary for special education pupil program, but who knows, maybe they'll start to try to do something like that for either the continuum of care reform or the POS, or who knows in terms of what they'll do. And then they said they anticipate posting that by July 1st, 2018. Although, to be honest with you, I think it's highly unlikely. Well, I don't know. That would be, that's like 2 months from now. So we'll see if that actually occurs. And again, just to look at the form itself, hopefully you have taken a look. The biggest thing that caught me off guard, like I said, was that you now have the ability to type in this continuum of care reform as the settlement type, as well as on the 1960, you've got this continuum of care reform administration that you're supposed to identify separately. Both of those result in a state general fund payment. So, and I would anticipate some of these other changes, again, like we talked about, that you would see those same sort of changes be implemented just like that, where we may see a new settlement type or be part of that settlement type, or, again, for some of this administration and utilization review associated with the Medicaid final rule, I would think we'll potentially see an additional line on the 1960, but I'm just guessing. So any other input on the cost reports or any questions?
There's a question going back a bit. Do we have a current method for distributing fiscal year 16-17 growth and how that will be calculated?
So the answer is no. The approach, or the recommended approach that was supposedly used for the 15-16 approach, I think has been proposed to be used for the 16-17 growth, which is a combination of actual claim data and risk-adjusted beneficiaries. And I think it was CSAC put out a letter on that approach, and I can email that to Shoshana and she can send it to you folks. But to my knowledge, there is not an agreed upon approach for 16-17 at this point, which is, again, why the growth hasn't been distributed. And this is a behavioral health sub-account that I'm assuming they're asking about. All right.
Another question.
Yeah.
Did you say DHCS has 3 years to audit the cost report?
They have 3 years from submission of the most recent cost report. Yes, that's in statute. And so what they do, this is, again, why they probably wouldn't say this is why they do it, but I think it, as part of the cost report process, and you guys, so you submit theoretically by December 31st following the close of the fiscal year. And, you're supposed to submit the certification and hopefully it's error free and everything else, assuming everything goes correctly. Technically, then a year and a half later, so basically 2 years following the close of the fiscal year, the initial settlement should occur where the cost report, the analyst at the state has looked at it, says it's good, it passes all the errors, and so they tell you go ahead and download the F file and make any changes to the units of service, and then re-upload that and resubmit a certification. Well, even if you don't have any changes, you're still required to do that because that is then becomes your most recent submitted cost report. So they have 3 years from when you submit your final F file to audit your cost report. So it's not, so even if you don't make changes, you still have to download and upload the F file, and they would look at that as basically resetting the clock, which is kind of frustrating if you don't have any changes. All right, we're running out of time. So I'm going to go through MHSA pretty quick. They give an update on the 25 counties have submitted the 1617 RER. They said all the prior years were submitted for the most part. And hopefully you've all received at least one reversion letter based on whatever you had submitted as of January. And so you kind of can see what the process is and the way that they're calculating reversion. There have been some appeals. I am not aware of anybody winning an appeal. And in general, the denial doesn't give you a whole lot of information. So just as a heads up, if you intend to appeal, unless you're finding an error in like their calculation, I think it's gonna be tough luck trying to get something an appeal approved. DHCS cannot finalize a reversion calculation until you submit your 1617 RER, so it's really important to get those in if you haven't as soon as possible. Then DHCS is supposed to come out with another info notice on what the plan requirements are under AB 114, because remember what happens is funds that would have reverted as of July 1st, last July 1st, basically revert and then are reallocated to the initial county. But then you've got to come up with a plan on how you're going to spend those funds by this July 1st. And there's really no specificity in terms of what that plan needs to look like. And so hopefully DHCS will come out with something soon. They also indicated in the information notice 17059 that they intend to withhold 25% of future MHA distributions if you do not submit a plan. And it takes some time because you can appeal and you can do some other stuff. But again, the bottom line is get your 1617 RER in so you can get the notice of how much funds the state considers reverted back to you, and so that you can start developing the plan. And in terms of requirements, you're supposed to post the plan to your county website by July 1st and submit that link to DHCS by July 1st. After posting, your Board of Supervisors has 90 days to adopt a final plan, and then you've got to submit to both DHCS and the OAC within 30 days of the Board of Supervisors approval a copy of the final plan. And technically you cannot, well, the state has said you cannot spend any of these reverted funds until your Board of Supervisors has adopted the final plan. They did give some guidance through that information notice on what the plan is going to have to do. It will have to account for all the reverted funds. So again, that's why you've got to get the 1617 RER in. You've got to go through the same. It needs to be part of either your regular annual update or as an update to the annual update, both of which require 30-day posting and all the stakeholder process. The other thing they said is that any reverted funds need to stay within the component. And so really the biggest thing that I'd be concerned about is if you're showing innovation funding reverting, which is where the majority of funds are reverting, what's unclear on this is whether, and I'm hoping this isn't true, that you have to have OAC approval for an innovation project prior to actually submitting a plan, or there were, I'm hoping the state will say, as long as you list in your plan an innovation project, that you still can then go to the OAC and get approval. Hopefully that will be sufficient. But again, more information coming on that. And actually, I'm thinking on the next webinar, I'll focus a lot more on MHSA, and hopefully we'll know some more information on some of this other MHSA stuff. So we can spend more time talking in detail. And then the last thing they talked about is that they are intending to do regulation package at the end of fiscal year 18-19, so the end of next fiscal year. The one thing that concerned me again is that they're talking about in the future when funds are reverting, that they're going to offset a future distribution. And that, again, I think from an accounting perspective and looking, each of you internally at how you account for these funds, and I think them doing offsets against future distributions is going to be incredibly complex in terms of making sure the accounting stays correct. It means that when you look at the SCO's website, the amount distributed isn't necessarily going to tie to what would be in your records, because you would basically, for example, have to take an amount of funding you already had and reappropriate it in a subsequent fiscal year, and call it new money. So again, hopefully you guys will have a chance to provide input into that. I would think it would be a lot easier just to cut the state a check out of a given component, rather than having to try to deal with this through offsets and everything else. I just think, especially in a small county, your accounting is going to get very difficult to track. So again, any questions on that? I can talk in more detail at the next webinar since we only have 10 minutes still. All right, so moving on to some of the stuff that was talked about in county to county, the AB 1299 presumptive transfer through Cal MHSA. So this is where the counties basically, or you guys are doing this to yourselves, you're setting up a process to exchange funds. When you have a placing county place a child in a different county, that the placing county ends up getting billed for the services, even though the host county pays for the services. It's not ideal, but apparently, again, this is more probably political. It's something that CSAC and apparently the directors and apparently DHCS wanted. They didn't want to mess with the behavioral health sub-account allocations, which would have been a super easy way to deal with this. And given the claim lag, it eventually catches up anyway. So you're really just dealing with it for 2 years. But and I understand in listening to the call or the Financial Services Committee meeting that you folks were actually, or the financial folks were against this process, which is good to hear because I am too. But it sounds like it's going to go forward anyway. And so just be prepared again for more tracking, reporting. I have a feeling the placing county is not going to get much in the way of administration reimbursement, both from the admin cap as well as the way auditors are probably going to look at this. But anyway, that's what's going on. And given that folks aren't willing to look at the behavioral health sub-account, it probably is the best approach. We talked a little bit about the behavioral health sub-account, again, going back to that diversion for drug Medi-Cal, that letter was a little stronger than it probably needed to be. And I think, again, DHCS is just trying to force folks to get on the drug Medi-Cal bandwagon. What's also then interesting though is then they're playing super hardball on some of these rates and some of the requirements. So it's anyway, I don't envy a lot of you, especially really small counties. There are a lot of barriers, and DHCS isn't really helping you out, it seems like, on some of this. And lastly, on the budgeting with behavioral health sub-account, looking at the OIG potential offset or recoupment of 230 million, just to keep in mind that there is 98 million of 16-17 growth. We're estimating about 100 million of 17-18 growth, which would then increase the 18-19 base by about 100 million. So that's about 300 million over the current 17-18 base. So if you look then at how much statewide is used for mental health versus SUD, it's about 80%, which would mean of that 300 million, potentially, 240 million could be available to help with the OIG offset and recoupment. So I'm thinking from a general approach and being conservative, you may want to look at your budget for 18-19 as basically just holding the 17-18 amount flat, and any of this growth money or increase in base you could use to help for the OIG offset. And it probably won't be that much, but just as, again, just kind of some way to look at the OIG thing. MHSA reversion, the one thing there that we talked about in county to county was that everybody's focused on this AB 114 stuff and getting that right. Don't lose sight of the fact, for those of you who are counties with populations larger than 200,000, that you've got then by the end of this fiscal year to spend all of your your 15-16 monies, right? 15, 16, 16, 17, 17, 18. Yeah. So make sure you're also tracking that for the smaller counties that are under 200,000 population. We're assuming and hoping that the 5-year period that was put in place by AB 114 applies to funds that would have reverted after 7/1/17, so that you wouldn't be impacted by that. But for those of you that are larger, don't lose sight of the fact that you've got this other, especially on the PEI funds, that need to be spent by the end of this fiscal year. And then CBHCA brought up that the Public Hospital Association had reached out to them around cost reporting of public hospitals and primarily the audits and just the timing of audits. And apparently there's some audits, it sounded like, that are even older than the audits that we have under short-term Medi-Cal, and basically for the public hospitals to work with the Mental Health Association on how to work that through and make sure that the appropriate amounts get reflected in the short-term Medi-Cal cost reports. And I think there's only 27, if there are even that many short-term Medi-Cal hospitals still around. And then Karen came and talked about the CIBHS Fiscal Leadership Institute, and again, Shoshana brought that up. And if any of you want to get involved in the planning for that, and there are any specific topics you want covered, definitely shoot Shoshana an email, and she'll get that to Karen. So that, the Institute's for you folks, and hopefully what gets presented is information that is valuable to you. So with that, I'll open it up to any final questions and anything else anybody wants to talk about in the last couple of minutes here.
There are 2 questions. Can we resubmit RERs if our county auditor did not sign the submitted draft? So I've heard what fiscal? So for current fiscal or for 16-17? So yeah, I would just go ahead and especially if you didn't submit the certification, but you submitted an RER, I would submit a new RER with the certification. I'm somewhat surprised the state would accept it without the certification to start with, but yeah, I would submit it.
well, I've heard different things on whether you can submit, if you had submitted an RER with a signed certification, I've heard different things on whether you can then submit a revised RER. I've heard sometimes they're saying yes, sometimes they're saying no. But I would think for 1617's RER, you want to try to get that right. You definitely, I would probably resubmit if I didn't have a certification already signed. And if they, worst case, they come back and say no.
Mike, there's a clarification on that question. She wants to know for earlier years, 11, 12, 12, 13, 13, 14.
Yeah, I don't think you can because they've already done they've already done the calculations, but that could go into your plan in terms of how you're going to, if it resulted in reverted funds, because that's really what they're focused on, then that would be how you would use the funds would be, or you would put in your plan that actually this occurred, and so the funds aren't there. But again, we need to see some information or some guidance on what these plans are supposed to look like. If it didn't result in any reverted funds and has no impact on that, then when you submit your next RER, you would do adjustments for those prior years. So you don't really need to submit a revised RER for those years. You would just submit adjustments on the next RER. Was there one other?
Okay. One other question. Do you have MHSA revenue predictions for next year?
Nothing different than January. I haven't seen the annual adjustment amount, which should have been communicated to CBHDA, but CBHDA hasn't come out with anything. So I don't have anything different than what actually the webinar that we did in January at this point. I'm hoping to, I'll for sure have something by the next webinar. But at this point, I just would base it off of what I presented in January.
Okay, that's it.
Okay, right at noon. All right, thank you. Like I said, or Shoshana said, our next webinar is coming up next month, so pretty soon. I would like to focus on MHSA, it seems, would be a good topic. If there are any other topics you would like me to cover, let Shoshana know, and we'll try to incorporate that into the webinar. And that's it from my end.
All right. One.
Okay.
Thanks,
bye-bye.
Mike. Bye.